Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Great. Thank you for coming. I know it's not the best weather outside, so I appreciate everybody braving it, coming in. My name again, as Kathy said, Sunil Upender. I'm one of the radiologists here, and my particular interest and my subspecialty training is actually in breast imaging, so that's why this is important to me. And in the past 4 or 5 months, there's been a lot of controversy in some of the mammographic guidelines that have previously been practiced and kind of still are being practiced, but there's been a lot of debate. And particularly with all the healthcare reform that's going on, I think it's a pretty important time to be aware of this and just your own healthcare, as things are definitely going to change in the next few years. So just some simple facts. Breast cancer, it is the most common cancer in women, and it's the second leading cause of death in women. So it's clearly a prevalent, important disease. It's second only to cardiovascular disease. And basically, in a lifetime, women have a 1 in 8 chance of developing breast cancer. So quite common disease, but don't think people die from that. It's just 1 in 8 actually get it throughout their lifetime, and that's up into 80s, 90s. So what is our defense? Something that most of you probably do or should do is clinical breast exams, and also that our defense is clinical breast exams from your physician, and then kind of in my field is imaging of the breast, either by mammograms, ultrasound, MRI, and as new technology, it's going to introduce some new things down the road. So that's kind of our best defense. Why do we do that? Basically, the goal of screening mammography is to detect cancers when they're small. It's been well studied and known that basically for breast cancer treatment, the smaller the cancer, the better the outcome. And the earlier the stage, also the better the outcome. Additionally, mammography has been proven to be beneficial. Since the onset of regular screening mammogram, since the program really started in 1990, there's been a decline by 30% in breast cancer mortality. And the prior 50 years before that, the cancer mortality rate was flat. It was stable. So clearly, there's been some improvement, and it's about 3% per year. There's been numerous studies, both here, Europe, all over, that have just documented study after study, and is literally just all but one study showing that there is a benefit and reduction in mortality in mammography. And the amount of benefit ranges from 20 to 40%, depending on studies. Some most recent studies have shown actually up to 39% reduction in breast cancer mortality. And in Sweden, where they've implemented a relatively new screening program, it's shown that 40% reduction in breast cancer mortality in women in their 40s. And that study also showed that it's a lot of this, you could say, well, things have been improving. Is it all due to imaging? And it's not. Breast therapy has also improved, but the studies have shown that 3/4 of this improvement is due to mammography, and then other advances, including therapy have improved mortality. So it's beneficial. So that's why there are certain recommendations that are out there. And these are the recommendations by all the big societies that do this, including the American Cancer Society, the College of Radiology, Society of Breast Imaging. And these are the recommendations. For an average risk woman, basically the recommendation is quite simple. You start mammograms annually, and you start at age 40, and you keep doing them as long as a woman is in good health. So it's a pretty simple recommendation. That's the current recommendation. If a woman has any high-risk factors, and some of these include BRCA mutations. It's a genetic mutation that's found in some family lines. The recommendation is to start earlier at age 30. Also, there's some computer programs that your clinician can determine your lifetime risk. And if it's greater than 20%, and that's mainly determined by family history and other factors like the age of menses, age of when you've had your first child. So it's a mathematical model, and it determines your lifetime risk. And if that is also high, they recommend starting at age 30, or 10 years before the family member that was first diagnosed. So if someone got breast cancer in your family, your mother was 45, then you should start at 35 and continue annually. Also, high-risk patients are women that receive mantle radiation, often in their 20s to 30s for leukemia. And then you should start mammograms 8 years after you finish treatment. And then if any biopsy has proven certain high-risk lesions, such as lobular neoplasia, atypical ductal hyperplasia, ductal carcinoma in situ, these are all some of the results that you may get from a biopsy, or in fact invasive breast cancer, then the recommendation is to start yearly from the time of diagnosis and to continue, regardless of your age. The other risk factors, the recommendation really shouldn't start before 28, even if you have some of those risk factors. And then when to stop, the recommendation is to keep continuing annually. And basically when you're not going to act upon the recommendations from the test, whether that if we're recommending getting a biopsy or if it is cancer to undergo treatment, if you're not going to be able to do that, whether out of personal desire or just you have other comorbid conditions, then it's recommended to stop. So basically, to summarize, what is the current recommendation? Yearly mammograms, start at age 40, and continue as long as a woman is in good health. So it's pretty straightforward. Now I'm going to describe what the recent changes and what you might have heard in the news over the past few months. And there's a large study that came out by the United States Preventative Services Task Force, and they published this data in November. And basically, their recommendations, they broke it down into age groups. Basically, if you're age 40 to 49, the recommendation isn't to do a screening mammogram. Actually, you could just wait till you're 50. They recommend, you can talk to your doctor and see if there's any high-risk reasons that you may want to start earlier. But basically, they're saying start at age 50. And then if you're 50 to 74 years old, the recommendation from them is you have a screening mammogram, but it's every 2 years, as opposed to every year. And then also, once you get to 75, they're saying that there basically was not enough data for them to make a recommendation, but basically their thought was that you should stop unless there's a pressing reason. So again, the summary, age 40 to 49, they're not recommending getting a mammogram. Just wait till you're 50, unless there's some risk factors. And then 50 to 74, you should get a mammogram, but every 2 years. And then if you're over 75, probably not, there isn't enough data is what they say to continue. Now, so this is just one organization that published this data. All the other organizations that I went over that already have the current recommendations, they don't agree with this. They may change their minds in the future, but currently none of the national leading organizations support this. And you may say, well, what's the big deal then? But I guess because it's published, it's out there, it's causing some discussion, and especially since it's government-based and there's all this healthcare issues, people are listening to that, which is fine, which is, you know, it's, whenever studies come out, it's good to hear their perspective. And that's kind of my, the point of me being here. I want to describe what they're talking about and then leave it up to you whether you agree or don't. You know, one thing to understand is that this task force was composed of 16 members, and you know, they had different types of people in there, people interested in health policy, public health specialists, even some people from insurance companies, and some primary care docs. So that's good, that, you know, that's part of a good group, but they didn't include everybody. They didn't include specialists in the field, breast imagers, radiation oncologists, medical oncologists, or gynecologists, and these are the doctors that are often dealing with breast care and breast treatment. They weren't allowed on the panel, and then afterwards they weren't allowed to comment about it, or, you know, it was already out there. They, some of them actually tried to talk to the group to see, you know, where are they coming from, and they were just dismissed, and these were experts in the field. So there's some, reading the fine details of their paper, it's interesting, they actually agree with a lot of what's already believed, and it does kind of contradict what their final recommendation was. But so, for example, they do agree that breast cancer mortality has been decreasing by 3% over, you know, since 1990, since the advent of, you know, a screening program in this country. And they even say that this, you know, direct quote is that this decrease is largely attributed to the combination of mammography screening with improved treatment. And, you know, their own analysis of the data, they say that there is a statistically significant reduction in mortality from screening mammograms if you start at age 40. And then also if you do it annually, it's also beneficial. But one of their concerns is that the harms associated with screening early outweigh the benefits. And, you know, the harms, and it's understandable, you know, the harms when we ask a patient to come back for additional views to see whether something is real or not. Sometimes we'll recommend a biopsy. And, you know, those are all anxiety-provoking things, so it's understandable. But at the same time, studies have shown that women would prefer that anxiety to at least know, and to know in the end, you know, whether they have cancer or not, they're okay. And additionally, looking at the age groups again, this study showed that basically to save one woman's life in their 50s, you'd have to screen 1,300 women. And they said that that's a good, you know, that makes sense to them. But in a younger woman, in their 40s, you'd have to screen a few more, 1,900 women. And so then that comes down to a cost-benefit ratio, and they thought that wasn't appropriate, that you'd have to screen too many people to save a life. Additionally, they said that if you start at age 50, you would sacrifice 30 years of life per 1,000 women. So they are saying that it is, the way it is currently, it is beneficial, and to change it would cost some lives, but it's not economically beneficial. Additionally, their recommendation once you're 50 is to have a mammogram every 2 years. And their own data says that that's good, but it's not as good as it currently is, and you would only preserve 81% of the mortality that we currently have. So again, it's good to do it their way, but not as good as it currently is. And again, in older women, they themselves say, breast cancer is a leading cause of death, though, in old women. So benefits of screening should be important, but they still advise against it. Okay, so what do we do? There's this data, this data is out there. There's a lot of debate about it. So do you practice it? Do we do what is currently being done? So first of all, you should always just talk with your doctor. Just, every woman's situation is different, and take it from there. But there is a clear benefit to mammography, and there's a minimal risk. So I kind of broke it down into age groups, and what I think is a good idea. So ages 40 to 49, they're saying just hold off, wait till you're 50. Basically, from the data that we have now, one invasive cancer is found in every 556 mammograms in women in their 40s. So you would be missing that, and 556 mammograms isn't that many. It's not that many people. Additionally, of all the new invasive breast cancers in all age groups, nearly a quarter are from women in their 40s. So you would be missing that huge chunk, a quarter of all these invasive breast cancers. Additionally, reduction in mortality with mammography in the 40s, as I said before, has been shown to, it's been beneficial and reduce mortality. So additionally, women who develop breast cancer in their 40s, their cancers are actually more aggressive. So again, you're missing a big chunk of women by waiting till you're 50, and of those cancers, they're also often aggressive. So they're dangerous things to be missing. Additionally, their recommendation is, well, you should speak with your doctor, see if you have any high risks, and then maybe consider a mammogram. But nearly the majority, 80% of breast cancers, there's no family history. It comes up, none of your moms, aunts, nobody's had anything. You're the first. So the majority are still without a family history. So you'd, once again, be missing a big population. And again, as I mentioned, the aggressive cancers would be missed. So what if you're 50 to 74? They're saying screen every 2 years. And as I said already, doing annual mammography has been shown to reduce mortality. And biannual mammography would miss 19 to 33% of cancers. So again, it's good if doing it every 2 years, but not as good. You're going to be missing a good chunk, a third of cancers. Additionally, doing a mammogram from year to year, it's easier for us as breast imagers to see subtle changes and catch things early, as opposed to waiting every 2 years. And additionally, between schedules and forgetting, it's not going to always be 2 years. It may be 2.5 years or 3 years between a mammogram, and that's a dangerous period of time to be, to have your breast not examined or imaged. And this chart basically says the earlier you find it, the greater the survival rate. So stage 0 or 1, great survival rate for breast cancer. And that is why breast cancer mortality has been reducing, has been improving. Basically, find it early, women do better. Additionally, the therapy is also going to be less invasive and less disfiguring the earlier you get diagnosed. The morbidity, personal grief, and cost increase as you get older, as pick it up later. Basically, if you find something early, you could just have a lumpectomy, local treatment, as opposed to if it's an invasive cancer, you waited too long, you're going to require a mastectomy and chemotherapy. So just much more treatment would be necessary. Additionally, you know, we call patients back often, meaning that you come in for a screening mammogram, we see something, we're not sure what it is, so we'll call you back, we'll take some additional views. And the majority of the time we'll be able to determine that that's nothing worrisome, and then you can go back to your yearly screening mammogram. And part of that benefit is that we have prior comparisons, and we have comparisons from the prior years, and that helps us and helps you in the long term. If we're waiting every 2 years, we're not going to have that same data to compare, and things are going to have changed. So we're going to probably end up, my prediction is that we'd be calling you back more, which would cause more anxiety. And not that we want to, it's just that there hasn't been as close of a surveillance. Now, what do you do if you're older than 75? Do you just stop? And, that really doesn't make sense. There's no difference between a 74-year-old and a 75-year-old. And in fact, women in their late 70s actually have the highest incidence of breast cancer. So again, that's a dangerous population to just stop screening and just let them be. And additionally, a mammogram becomes even easier for us to evaluate, and it's actually, we're able to be more specific about it and say this is cancer or not. And there's been studies of like one study showing women in their late 60s to 79, and that looking at screened patients versus patients that didn't have screening mammography, and again, the incidence of breast cancer was significantly reduced. So again, if you're older than 75, you should speak with your doctor, but I personally don't see that there's a reason to discontinue mammography if you're healthy and you're willing to undergo either additional views, additional biopsies, or treatment if need be. So how about high-risk women? I addressed this a little bit earlier. So basically, the current recommendation, and I agree, is basically to start at the age of 30 or 10 years before the age of the youngest first relative. Additionally, high-risk women can undergo breast MRI. That's a great study that picks up, it's very sensitive, it's able to pick up very small cancers. So that's another option. And there's going to be other options that are going to come up as technology changes. Now, mammography doesn't find all cancers. It's not a perfect test. It's not like a pregnancy test that, yes, you have cancer or you don't. It's a probability, and we can give a probability of whether this is going to be cancer or not. And mammography does miss 10 to 15% of breast cancer. So it isn't a perfect test. I think in the near future, things will change, and mammography may become obsolete and be replaced by some newer modalities, including breast MRI. But at this time, it's the best screening study we have, and it's been proven to be effective. And there are risks, and as I mentioned, additional follow-ups and biopsies are stressful, and that's not fun. But overall, of all the patients that are screened, only 2% ever end up needing biopsy. And of those, they're not all cancer either. The majority aren't cancer. So, it's not as many as we fear. But again, it's the best test we have right now. Additionally, the task force made some recommendations against self-breast exam. They said that there's no benefit to doing your own self-breast exam. And then as far as a clinician, a doctor doing your breast exam, they said that there's not enough data to say whether that's helpful or not. Again, personally, from my perspective, there's so many cancers that we find where, you as a patient comes in and you feel something because, you've been feeling your breasts monthly for years and you're able to find subtle changes. So, again, it's a little risky to just say that you shouldn't have these exams, either by yourself or by a doctor. So what has this task force done? They actually, make conclusions that mammography is beneficial. And, they gave all this data saying that what we're doing right now is good. But yet they draw a different conclusion. They reviewed all the literature that's out there, but they also selectively picked out what they were evaluating and reading, ignoring hundreds of respected journal articles. Additionally, they just kind of made these recommendations, published it, and put it out there. They didn't allow any peer review, any experts in the field to actually review the data, which is done for every other publication. You can't just publish things. You have to have other experts kind of look at the data, see whether it makes sense. But I don't know if it's because it was government funded and it was a government task force, they were able to kind of just put it out there. And once something's out there, it's, there's a lot of media attention and it's able to get a lot more attention. And, I may be jaded, but I think other people agree that, what's possibly behind some of these recommendations. And this came out roughly around the time that, Obama's healthcare reform started really taking effect. It's money. And, they state that money wasn't a consideration. That's what they state in their paper. But at the same time, they're making recommendations based on what is the most efficient. They're agreeing that what we're doing currently is helping and saving lives, but it's not the most economically efficient. And then they pick some random ages, saying that older than 75 isn't cost effective, and that screening women in their 40s isn't cost effective. So to me, it does seem like financial costs were part of their motivating factors for this report. Additionally, now that this recommendation is out there, other government associations, including things that make Medicare determinations, they're allowed by the government to actually take these recommendations and use them as proof, even though experts and specialists in the field don't agree with it. Because this is out there, they're able to act upon it. Also, private insurers may also incorporate some of this data, and even though it's not been proven, they're insurance companies, and they may want to, because in the end it does save money for them to do fewer mammograms. And a relatively recent study put out by the Avon Foundation for Women looked at a number of breast centers across the country, and this is just a couple of months ago. And this survey was basically to look at what's been going on across the country. Has this task force made an impact? Because even though none of the major organizations have changed their minds, has this recommendation done anything? And it looks like it has. There's been a 24% decrease in women under their age of 50 seeking appointments for screening. And, can't blame them. You see it on the media saying that, you can wait till you're 50, you're busy, it makes sense, just wait till you're 50. Some experts are saying wait. So it's an easy conclusion. Additionally, a quarter of the states have changed some of their government-funded programs, like the breast and cervical cancer early detection programs, to not include or to reduce mammography, and California is one of them. So basically, it's given this study, this recommendation, has given fuel to insurance companies, and it's also given rationale to kind of put off an exam that, I understand isn't pleasant. It's often can be painful, so I don't blame him to kind of put it off, and especially if you could put it off till you're 50, or put it off till, every 2 years, it sounds like a good thing because it's less painful, so it makes sense. But in the end, it's kind of confusing patients, doctors, and government policymakers on what to do. And I just going to read some excerpts from some experts in the field. And this was actually a mentor of mine. Basically said, these new recommendations seem to reflect a conscious decision to ration care. If Medicare and private insurers adopt these incredibly flawed USPSTF recommendations as a rationale for refusing women coverage of these life-saving exams, it could have deadly effects for American women. Another expert in the field. I can't help but think we are moving toward a new healthcare rationing policy that will turn back the clock on medicine for decades and needlessly reverse advances in cancer detection that have saved countless lives. So as that chart early on showed, but after 1990, the advent of screening mammography, there's been a nice decline by 30% in mortality. So we're kind of going to go back to the pre-1990 era. These recommendations, another quote, are inconsistent with current science and apparently have been developed in an attempt to reduce costs. Unfortunately, many women may pay for this unsound approach with their lives. So what's the bottom line? Nearly all breast cancers can be treated successfully if detected early. Key to early detection, annual mammograms, regular clinical breast exams, and monthly self-breast exams. It's kind of what we're doing currently. This is just an example. Can't really see the fine detail, but this is a mammogram. This is a patient that's been called back for additional views. That round thing is kind of, it magnifies the area that we're worried about. And there were a few microcalcifications. This is a young woman, 42, no family history. This ended up being cancer. And with the recommendations, she would have probably waited till 50 if that's what everybody was doing. And if that's what the insurance companies are, if they change their policy and you wait till you're 50. And by 8 years, maybe that would have stayed a small cancer and it wouldn't have affected her life, but maybe not. And she's 42, young. I don't think it's worth the risk. So again, thank you, and I can take any questions.
You said the family history. Does it have to be only breast cancer, or it can be something like other cancer?
Also can be ovarian cancer. There are that model does take into other cancers, particularly ovarian cancer, endometrial cancer. So there are other cancers that kind of figure in that model. For breast MRI, it also there's also, you use that same model to determine whether it's beneficial to get an MRI, because I said it is a great study, but it's also a little too good. It'll pick up a lot of things that aren't cancer. So again, the average risk woman shouldn't have a breast MRI. That's the current recommendation. But women with family history of breast cancer or other cancers should consider that, or some of the other things that I mentioned.
Did Medicare change from annual to every 2 years?
They haven't, but they can, and the government has given them permission to use these guidelines. But at the same time, I think there's been so much controversy, I think they haven't jumped on it, but it can happen, and it can happen overnight. But currently it's still okay. I know, for example, the Kaiser system, at least a couple of the local ones, have changed and have adopted that policy, you know, to screen every 2 years. So, you know, things are changing.
I guess my question is, how can we counteract this as in the public? I mean, what can we do?
I mean, I think coming here, that's great. I appreciate that you guys came here because, you know, being educated is definitely the first step because the news, as we all know, just puts their own spin on it. And so, you know, now that you have this information and you hear it on the news, you can kind of say, hey, wait a second, they're not looking at it from this angle. So education. And then talk to your doctor, and also there's a lot of government associations and congressmen and things that you could, you know, submit and say, you know, give personal stories and say, hey, I had breast cancer. You know, anything like that is definitely helpful, especially in the local, you know, state-wise. And California is already kind of going down that dirty, bad way with their breast and cervical cancer early detection programs. But in the San Francisco area, probably because of people talking about it and bringing it to attention, they actually haven't changed their local recommendations, and they are offering free mammograms.
There is a bill introduced in the House by a senator from Indiana that's countering that the insurance companies cannot change their screening policies with the new health care reform, so we are able to have our mammals once a year. So what I would suggest is just a quick little fax to your senator, your United States senator, and say, hey, I support screenings on an annual basis. And it wasn't just mammals, it's all kinds of screenings they're trying to keep as they are now. So in the health care reform, if it should pass, it can be rationalized. And so we kind of have to get right into it now and say, hey, don't tell me I can't have a mammo when I want a mammo. You know, Medicare pays a little over $100 for a mammo, so we're not talking a lot of money. But if you have cancer, you're going to cost the government thousands. So we have to look at it at a practical standpoint.
Definitely.